All right. So before we dive into PCOL, I want to just show you guys something just as a refresher. So I put a link on Google Classroom that brings you to the tutoring Google Drive fourth year, second semester. Specifically, I want to show you virology because this is going to be uh, the class that a lot of people struggle with because it's a combination of the three other classes. Um, I have a spreadsheet that puts all the information together for you. Here's everything you need to know. It's all written out for you. I have to double check it again. But here's all the stuff that you need to know. Including once you get to the second exam, when we start talking about all the different diseases, all the different uh, conditions and how to treat them and what to do if, what's your drug of choice, what's the alternative, the penicillin allergy, all that sort of different stuff. Um, the I'll explain more of this as we get into virology and kind of where this is all coming from. Um, and I'll upload a blank version of this so that way you can practice on your own. But just know that this is here for you to reference as well. Um, in terms of PCOL, um, oh, I don't know. Thera. Did I start doing it in Thera? Or maybe I started doing that fifth year. Let me double check. Oh yeah, that was fifth year. Okay, never mind. But this virology one is here for you to use as we go through that. All right. Any questions before we dive in to PCOL today? All right. All right. Then let's talk about opiates. Everyone's favorite topic, their favorite thing to take.
I love me some Fent, not gonna lie.
I prefer carfentanil myself. Uh, all right. When we talk about uh, the opioid system, we have to understand how pain is transmitted from the periphery to the CNS and then how the CNS modulates that pain. Keel has a really, really good diagram where he shows how a peripheral neuron will complex with the dorsal horn in the uh, CNS, which goes up to the brain. Here's someone's brain. And then how this can be modulated back at the dorsal horn. And for all intents and purposes, this diagram is really what you should be focusing on when we talk about the mechanism and the pharmacology of opiates, because it really doesn't get any more advanced than this. That being said, what I want to, oh, maybe if I type in, um, there we go. Okay, I found it. Nope. Uh, there we go. So let's go through and let's break down what this diagram is talking about and how all these different how this interfacing takes place. The first thing that we have to look at is this incoming periphery nerve here. Did I draw these the wrong way? Oh, that was dumb of me. I drew them the opposite way. You're gonna watch me stumble as we get through the beginning of tutoring, starting up tutoring again. Here's the brain, and then our mu opioid receptors. All right, like I was saying, so it all starts with the painful stimulus that happens in the periphery. So maybe this is slamming your hand in a car door, maybe you burned yourself, but regardless of what's going on, you have the pain signal being transferred along the primary sensory neuron. So the painful stimulus starts outside of the brain, outside of the CNS, and then it has to travel to the brain in order to be modulated. What ends up happening is that at the dorsal horn, we see the sensory neuron interacting with the ascending neuron. This is how the painful signal is sent up into the brain, where the brain senses, oh my God, something bad just happened. And then it modulates that signal once it recognizes and it takes some sort of action via the descending neuron. And so it's always going in this sort of pathway. First, it goes to sensory neuron, then the ascending neuron, and then the descending neuron. What using drugs does is skips this process where instead of going step 1, 2, and 3, we're just directly going to part 3 and reducing the incoming signal. And that's really where the opiates come in. Where we care about them is looking more specifically at this synapse. Am I recording? Yes. Looking more closely at how the ascending and the sensory neuron are interacting, we can see how the sensory neuron is releasing primarily 2 substances. The first substance is glutamate. The second substance is known as substance P, where I believe the P stands for pain. Essentially, the important thing to know here is that both substance P and glutamate are excitatory neurotransmitters. And that should make sense, right? If the sensory neuron is trying to tell the brain that something happened, then we need to use excitatory neurotransmitters in order to get the brain aware of what's going on. Each one of these neurotransmitters is going to go to a different receptor found on the ascending neuron. For glutamate, glutamate is either going to the AMPA or the NMDA receptor. depending on which region of the spine and where the sensory neuron is coming from, you're going to get different concentrations of AMPA and NMDA. We're not really going to focus on that right now, but what we can say is that either one of these, both AMPA and NMDA, are two things. The first is that these are glutamatergic receptors. Why are they considered glutamatergic? Because they are activated by glutamate. The natural ligand is glutamate. In the same way that nicotinic receptors are activated by nicotine, even though that's not the, the official endogenous chemical, we name things after the substance that we find that activates them. The other thing that we should know here too is that these are ligand gated ion channels. So breaking down this meaning, what is the ligand? Who can tell me what the ligand is that activates this ion channel? Yeah, very nice. It's glutamate, right? And then what is the ion? What is going to be the ion that is going to stimulate more and more neuronal activity? I'll put it to you guys this way. What is the very good guesses? So the question becomes, we're depolarizing the cell, right? We are causing the cell to be more likely to be activated. And so there's really two possibilities. Not potassium, so in this case, it's going to be calcium. You're not necessarily wrong for thinking sodium. And the reason is because when we look at the barrier here, in order to have a what are they called? Action potential, you need a positive inner charge, right? This is what depolarization is. Calcium and sodium are extracellular and they move in flux. Potassium is positive, but it moves via efflux. So if we had a potassium channel, we'd be making the cell more negative and hyperpolarizing it. So that's why it's not necessarily potassium in this case, but you could guess that maybe it's sodium, maybe it's calcium. In this case, I'm telling you it is calcium. Any questions about this so far? Okay, great. So that covers glutamate and our glutamatergic receptors. Next, we have to look at substance P, and this is going to go through the NK1 receptor. Unlike AMPA and NMDA, the NK1 receptor is a GPCR. If you had to guess, what GPCR do we think NK1 is? Either GQ or what's the potential other one? Not GI. Remember, substance P is an excitatory neurotransmitter, so we're stimulating the cell. GS. Very nice. So, and I'm just double checking my work. Before I give you guys the wrong. Yeah. So some of them are GS. I would say the majority of them are GS. Some of them are GQ, depending on where they are in the body. But if you have to think about what kind of GPCR the NK1 receptor is, think GS. The important thing to know about these three receptors here is that they all ultimately do the same thing. They all ultimately bring pain signals from the outside of the body, outside of the CNS, up into the brain. That's really all they do. What ends up happening here is that stimulus goes up into the brain recognizes it and causes some sort of action. That action is probably going to be like moving your hand away from that hot stove. It could be gripping your finger. It could be, jumping up and down, whatever it is, the body is going to have some sort of reaction. Over time, the brain is going to become very, very fixated on that pain. And so the brain needs to have a way to cut down that incoming signal that we already dealt with, right? We already took our hand away from the stove. We don't need to know that we're still in pain. And so this is where we end up getting our mu opioid receptors coming in. And I'm just gonna bring this down a little bit. So in the brain, the body releases certain chemicals that end up binding to the mu opioid receptor. This is what really always confused me about when he drew this diagram, is the way he draws receptors is like this, and I always thought it was just an M. It was like, why are there mu opioid receptors everywhere? They're not. They're just receptors. And I always felt that was needlessly confusing. Which is why you will see me draw them like this. The mu opioid receptors will modulate the incoming signal. And they do this by releasing a couple of different chemicals. The first is norepinephrine, and the other is serotonin. Now, when we talk about how the mu opioid receptors are decreasing the incoming effect, how should we classify these neurotransmitters? Would they be excitatory or inhibitory neurotransmitters? Inhibitory. Very nice. Now, we haven't ever talked about serotonin yet. And what you should know about serotonin is that it binds to uh, dozens of different serotonin receptors. But uh, all of them are going to be inhibitory in some nature. They're decreasing the action of the cell. Uh, duh, duh, duh.
And he was like, wait.
When we talked about norepinephrine previously, in a way, norepinephrine is it can activate certain aspects of the body. What I mean by that is that norepinephrine, when it works on alpha 1, is activating, right? GQ. So in order to get norepinephrine to act like an inhibitory neurotransmitter in this sense, we are going to be using the alpha 2 receptor. Why? Because if we remember, alpha 2 is GI linked. So once again, we're seeing how the alpha receptor is being used in this interesting way where we're decreasing the effect of other things. Same thing with serotonin. It is GI linked, and it is going to decrease the effect of the sensory neuron. How does this happen? Well, when we talk about alpha 2 or the serotonin receptor being activated, what's going to happen first is that we get we have GI activation, which is going to lead to a decrease in adenylate cyclase, which is going to lead to a decrease in CAMP. And we know that CAMP is all about the function of the cell, right? So activating either one of these receptors is going to make the sensory neuron work worse. The other effect is that we open potassium channels. Based on what we talked about earlier, we know that opening potassium channels is going to polarize the cell, right? So we're going to get hyperpolarization, which means that we're going to get less vesicle fusing. And ultimately, what this means is less substance P and glutamate release. So two effects of mu opioid receptors, right? First, the brain activates a mu opioid receptor, which we should say that. So we have mu opioid receptor activated. This is going to release norepi and serotonin, which will then come in and activate their respective receptors. Any questions about that? Okay, great. This is the primary function of opiates. This is how they produce that potent analgesic effect. The other aspect of how they work is in the other locations where we find mu opioid receptors. One of the biggest places that we also see them is on the ascending neuron. So in this case, having this mu opioid receptor here is going to, so we have the ascending mu opioid receptor. This is going to hyperpolarize the cell, which is going to decrease the NMDA, AMPA, NK1 effect. Likewise, at the location where the pain happened, so in the periphery itself, we also have mu opioid receptors. And so what the peripheral mu opioid receptors are doing, these are decreasing, these are hyperpolarizing the sensory neuron, which is going to decrease the pain stimulus. And so when you look, all of the different sections where we have the incoming stimulus being transmitted, we have opioid receptors doing their job. Any questions about this? Does this kind of clarify his diagram that he wrote up? Kind of, sort of. Okay. I found this diagram to be exceptionally confusing when I went through this lecture. I was like, I don't get it at all. All right. Put that over there. Mm. I don't know where that went, and I don't know where that went. Great. Sorry, I just want to find my diagram, but I don't know where it went. Ah, okay. All right. Now that we've talked about the mechanism of action, we can start to take a look at how the effect of opiates happens. In general, what we are going to be looking at is how opiates will activate the mu, kappa, and sigma, not sigma, delta receptors Maybe it's easier if I just do this. Mu, kappa, and delta receptors. This is going to decrease pain perception. And this gives us our analgesia. Great. That's exactly what we want. It doesn't always work out that way. And that's the big problem. When we activate when we activate these receptors, the acronym that I want you to think about is morphine CVS. These are all the pharmacological actions of the opioid agonists. All right, so let's go through these one by one. For M, we have meiosis of the eye. And what ends up happening here is that we get constriction of the pupils. And it's to the point where we end up calling them pinpoint pupils, especially in an overdose. One of the big toxidromes of opiate overdoses is this pinpoint pupils. Next up, we have our analgesia. Now we have our respiratory depression. And what's important to know here is that the effect on breathing is due to desensitization in the breathing center in the brain. In where is it? No. What ends up happening here is that opiates don't cause someone to stop breathing. What it does is it prevents the body from recognizing that there's a CO2 buildup. So normally when we have an increase in blood CO2 levels, this is sensed in the chemoreceptor. Just want to, yeah. Sensed in the chemoreceptors. And this stimulates a breath. What ends up happening with opiates is that the mu opioid receptor decreases the sensitivity of the chemoreceptors. This decreases the number of breaths. And then what ends up happening is that someone suffocates. It doesn't turn off breathing. It causes the brain to become so sensitive to the fact that we don't need to breathe that you're taking a breath once every 10 minutes. That's what the brain decides. Like, oh, I don't need to take a breath for another 10 minutes. And then, of course, the person dies. Next up, we have psychological or physical dependence. We'll come back to this in a second, just because the mechanism of how this happens warrants a larger discussion. H is for histamine release. What ends up happening is that the certain opiates cause a release in histamine. What ends up happening is that you administer the drug, and for a multitude of different reasons, this causes mast cell degranulation, which is going to cause an allergic reaction. In the same way that if someone with a peanut allergy eats a peanut, then they're going to end up getting, some sort of allergic reaction. This can be this can be as simple as things like itching, or it can progress to the breathing to the lungs, and you get things like bronchoconstriction, where it's taking on more of an aspect of asthma, that sort of thing. I is for itching, which of course is related to the histamine. N is for nausea and vomiting. I just wanna. Nope. I'll come back to this in just 1 second. E is for euphoria. And where this is coming from is the I forget actually how it ends up happening. I think it's that it decreases brain activity, and for some people that's seen as a euphoric effect. We'll talk more about this when we get into kappa, I think is probably the better place to talk about it, which makes more sense for me. All right. For C, we have 2 things. The first is cough suppression, which is known as the antitussive effect. And what ends up happening here is that you are desensitizing the kind of irritation in the lung. So what ends up happening is that you are you're almost providing like some numbing in the lung to prevent the need for coughing. The other C that we have is constipation. loads and loads of constipation. And where this is coming from is that peripheral mu opioid receptors are decreasing GI motility. And they're decreasing it significantly. What this means is a decrease in motility leads directly to constipation. It also leads to a increase in sphincter tone, which means that it's harder to get through the sphincter. So even if maybe the feces has reached the colon, it's harder for you to push the feces out. I guess I will double back. Talking about nausea and vomiting real quick. What ends up happening here is that while the body is becoming less sensitive to CO2, it's becoming more sensitive to stomach irritants. These are things like excess mucus, and so that's going to cause the stomach to feel queasy, and then you end up feeling really nauseous and throwing up. This is why just eating something can really help with decreasing nausea in this case. V is for vagal stimulation. And if you remember, vagal is rest and digest. Specifically, we are talking about its effect on the heart. And so this is going to cause significant bradycardia. Essentially, what ends up happening is that the body is saying, great, we're just going to chill out for a while, and we don't need to worry at all. And so you end up getting pretty significant bradycardia. And then lastly, we have sedation and hypnosis, which you guys, I think you might have talked about hypnosis so far, but we'll talk about it later. What ends up happening here is that we decrease brain activity. Which, of course, is going to lead to fatigue, drowsiness, hand-eye coordination issues. Ultimately, what this can lead to is coma, where you have so little brain activity that you are just asleep. The other thing that can happen here is that you're throwing off the balance of excitatory and inhibitory. And does anybody know what happens when you change the balance between excitatory and inhibitory neurotransmitters? It can lead to death, but in this case, we're talking about seizures. Seizures are very, very, very complex uh event that happens in the body. Sometimes it's because you have too much excitatory, sometimes it's because you have too much inhibitory, sometimes it's a combination of the both. But really what it comes down to is that you have to balance this stuff, and opiates can throw off, they lower the seizure threshold. So it makes it easier to have a seizure. Any questions? Does this make sense? Doesn't make sense? Okay, great. All right. All right. Um, he spent a ton of time going through all the different opiates and explaining, uh, what does what also activates what, all these different things. I'm not going to spend a ton of time um, going through all the like nitty gritty details, but I do want to point out some of the big categories of how we can um, kind of classify these different things. So specifically talking about the central mu agonists. The first category that we're going to look at is in terms of uh, their pharmacological action. In other words, what we're going to be doing is we're going to be ranking them based on, are they strong opiates? Are they intermediate opiates? Or are they weak opiates? Right off the bat, can anybody tell me what the only weak opiate is? What's the only weak opiate? Codeine. Very nice. All the other central mu agonists are either going to be intermediate or strong. Really, what differentiates between strong and intermediate is, are you a partial agonist? And if you are a full agonist, do you activate other stuff? Because that's really what's going to end up causing these sort of different differences that go on. Now, not every drug fits nicely into these different these different categories as much as I would like it to, but it does get us at least close to how we can group them. And I just want to maybe it would be better if I did it like, I'm gonna erase this for now, just so I can have room to write. We'll come back to this. All right. In terms of our strong, oops. Yeah. Mm-mm. Ah, okay. That's what I wanted. All right. In terms of our strong central mu agonists. What's really going to be the defining characteristic is that you have pure mu activity. It's really going to be your job. And so this is going to give us things like morphine, the fentanyls, which of course is regular fentanyl, alfentanil, carfentanil, remifentanil, you know, all those different sufentanil, all those different derivatives that we talk about. Tramadol is in here. And I should be describing why they're in here. So morphine is what we're going to be comparing everything to. So morphine is our base here. In terms of the fentanyls, these have a higher affinity for the mu opioid receptor. So they're going to be binding to the mu opioid receptor tighter, which means that they're going to produce more analgesia. Tramadol is comparatively similar to morphine, but it's also going to be releasing serotonin and norepinephrine. So we have a second mechanism of analgesia. So we're going to be able to activate the alpha-2 receptor. We're going to be able to activate the serotonin receptor, and that's going to add even more on top of what morphine would be doing. The next one we're going to look at is hydrocodone. The I almost want to go into medchem a little bit because it would help explain where these are all coming from. Hydrocodone is the ketone derivative of morphine. So where morphine is able to access the body, hydrocodone has slightly higher blood-brain barrier penetration. And so this is why hydrocodone is able to have this strong effect. The interesting thing with hydrocodone is that we generally don't administer it alone. The reason for that is because it's not, while it's better than morphine, it's not nearly as strong as it could be. So you have a couple of different combinations. The more common one is with acetaminophen. And really what you're just getting is two analgesia pathways. The other thing that you're getting with hydrocodone potentially is atropine. Does anybody remember why we would be using atropine? Or homatropine? Yeah, essentially what it is that atropine, if you remember, is a muscarinic antagonist. And what this is going to do is that it's going to cause bronchial dilation. And so this combination is helpful in cough. Right? So if someone is having tons and tons and tons of coughing, it's really, really hard to breathe. They feel like their throat is constricting. Then maybe we would give them Hycodan, which is used for the antitussive effect of the hydrocodone, but also the atropine. The reason why we do this is because either one of these combinations reduces the dose of the opiate. Right? I don't need to give as much hydrocodone if I add another pain pathway through acetaminophen. I don't need as much hydrocodone if I add atropine in order to dilate the airways. The cousin to hydrocodone is oxycodone. Oxycodone, in the same way, is usually given with acetaminophen. Again, this is mostly to decrease the dose, right? And part of this comes from the opioid epidemic, where we used to just give oxycodone by itself because it does a really, really good job. Now we give it in combination because we can hand out much, much less combination, less opiate in a dose. It also comes in an aspirin formulation. Acetaminophen is Percocet, aspirin is Percodan. I've only ever seen Percodan once, and that's because someone was allergic to acetaminophen and ibuprofen. Maybe they had liver failure, and that's why they couldn't do it. Can't remember. Is this helpful, by the way, to go through these like this? Or am I just repeating info that you already got? Okay. All right. I'll keep going then. Meperidine. Meperidine is, when we go to MedChem, we'll look at the structure. It's very, very similar to morphine. Really, the only thing to know is that it's very potent. It does the job, but it's only used in short bursts. So when you think meperidine, think, someone just got into a terrible car crash and we need to give them some pretty significant pain modulation, then we're going to be giving them meperidine. This could also be like you also see it in like labor and delivery. It's a really, really good drug for that. The reason why we do this is because it accumulates in the kidney and it can lead to kidney failure. So on the exam, which opiate can you not give in kidney failure? That would be meperidine. All right. A couple of other ones just to list them out. Methadone. Methadone can be used for pain. It has a really, really long half-life. Where I see it all the time is in substance use disorder. But the big thing to worry about with methadone is QT prolongation. This is definitely something you need to remember. You have to remember that methadone causes QT prolongation. That is definitely something you will be tested on. It was also in my Naplex. let's talk about the intermediate. While the strong drugs were because you were a pure mu agonist, you're in intermediate either because you were a partial mu agonist or you were a mixed agonist antagonist. And really, that's what's going to cause you to be a bad drug. So let's take a look at the first one, which would be buprenorphine. I don't know where it went. Actually, let's talk about what we mean by mixed agonist antagonist real quick before we do that. Of our three receptors, our mu receptor is related to the strongest analgesic effect. In order to get analgesia, you really, really, really need to activate the mu receptor. In sorry, lost my place. Well, I can't find it. Oh well. When we talk about the kappa receptors, we're talking about a moderate amount of analgesia, not nearly as much. And then finally, with the delta, we are talking about the mostly a minimal amount of analgesia and a good amount of sedation. More than kappa. Obviously, mu has a ton of it as well. When we look at our intermediate drugs, the first drug, buprenorphine, we primarily think about it in terms of how it is a partial mu agonist. The thing that you should remember about buprenorphine, however, is that it is a kappa antagonist as well. So when we look at this, you're getting 50% analgesia from mu, and then you're getting from the kappa antagonist, you're getting decreased analgesia. So this is why buprenorphine isn't a great drug for pain relief, because you're not getting anywhere near the amount of analgesia that we expect. So overall, what this means is that buprenorphine is a less efficacious opiate in terms of pain. where we're going to be using it is mild to moderate pain then, instead of severe pain or cancer pain, something like that. And then we'll talk about, in a little bit, we'll talk about its role in substance use disorder. The next drugs that we're going to look at are all going to be our kappa agonists. So their main function is based on kappa because they're also a mu antagonist. So we get some analgesia from kappa, but we prevent major analgesia. So all of these drugs are going to be only somewhat effective in blocking the pain that someone is going to feel. And really, all of these drugs fall into this category. So this would include nalbuphine, butorphanol, and then pentazocine, which goes by Talwin. And then pentazocine is combined with naloxone in its own kind of special formulation. Why are these drugs used then if we block the mu antagonist? The reason is because by using it as a kappa agonist, we get some analgesia, but we also get major or some dysphoria. And in class, he talked about how activating the kappa receptor causes this dysphoria, where activating the mu receptor causes euphoria. What this means is that the butorphanol, nalbuphine, pentazocine, you can't abuse, right? What would be the point of abusing a drug that causes you to feel like the world is, crashing down around you, right? It's a very, very scary is the wrong word. It's a very, very disheartening reaction. It really does make you feel like the world is a terrible place. Any questions about those? Great question. I think they do the naloxone so that way. I think it's because pentazocine specifically has the least amount of mu antagonist activity. So in other words, it's almost like a kappa agonist mu agonist. So technically you might be able to abuse it. So they put in naloxone so you can't snort it. That sort of thing. It's a really good question. I think that's what it is. I'd have to double check. All right. And then, of course, as we talked about, our weak is codeine. Why is codeine our weak mu agonist? Oh, good question. The ADRs. So let's group them by their mechanism. In terms of being a kappa agonist, The biggest is dysphoria. You get some sedation and some constipation. The reason why I say only some is because when you look at the number of kappa receptors versus mu receptors in the periphery or in the brain, there's just way more mu. So the effect of mu is much, much higher. In terms of being a mu antagonist, what it's remember, it's not accurate to just take the complete opposite of an effect, right? So if mu receptor normally causes euphoria, just because you're an antagonist doesn't mean that you're going to cause dysphoria. It's just blocking, the euphoric effect if you were to take it. What I would rather say here is that you get loosening, or the better actual term is decreased tone in the GI tract. So it's easier to kind of move things along. The sphincters aren't as stiff. So I don't want to say that you cause diarrhea. That's not really what's going to be happening. It's mostly that the GI tract is going to be a little bit easier to move around. But of course, that's going to be negated because of the kappa agonist. Of course. Really, really good question. And then in terms of weak, as we talked about earlier, we have codeine. The reason why codeine is weak here is because it is metabolized. So codeine is metabolized by 2D6 into morphine. The problem is that this is a really, really low activity. Sorry. It's a really, really slow process. I misread my label. What ends up happening is that codeine, I think, gets sent through 3A4 into inactive metabolites. So it's like we're dribbling out tiny bits of morphine at a time, which ultimately means that we're not getting a ton of analgesia. We're mostly getting antitussive effect. So if you need to give someone an anti-cough, go with codeine. If you need to give someone just a tiny bit of analgesia, do codeine plus acetaminophen, which is the Tylenol number 3, I think is what it is. That sort of thing. So when you think codeine, think cough syrup. That's really what it is. All right. So those are all of our central drugs. So we just talked about. So all the drugs that are working within the brain. What we need to talk about now is all the peripheral drugs. Yes, talk about the agonists first. So in terms of our peripheral mu agonists, what we are using them for is the anti diarrheal effect. So we're trying to take advantage of the fact that the mu agonists cause constipation. So why don't we just give a drug that doesn't cross the blood-brain barrier, but it will, cause the person to become constipated? There are two primary drugs. The first is loperamide. Loperamide is found over the counter as Lamodal. It doesn't cross what I should say, at low doses, doesn't cross the blood-brain barrier. Loperamide can be a drug of misuse because at high doses, it can cross the blood-brain barrier. The other one that you'll see a lot of the times is diphenoxylate. Oh, sorry, did I call this Lamodal? This is Imodium. This is Lamodal. Diphenoxylate is combined with atropine as a misuse deterrent. Unlike loperamide, diphenoxylate can cross the blood-brain barrier more easily. And so if you took enough of diphenoxylate at a time, you would be able to get that high. What atropine does, as we remember, as a muscarinic antagonist, is it's going to make you feel terrible. And so it's going to stop you from wanting to do it again. So you're going to get things like tachycardia. You're going to have blurry vision. You're going to have, you're going to be sweating. You're going to feel awful. So the question becomes like, why do it? And so it's a deterrent. If we talk about the peripheral agonists, we should describe the antagonists. And the really what these are being used for is as opiate induced constipation antidotes. So the way that you should be thinking about these is just like how Narcan, naloxone, is the central mu agonist antidote. These drugs are the peripheral mu agonist antidotes. So when someone takes opiates for a long, long amount of time, so you take your mu agonist, you're going to become constipated. You use your mu antagonist, you're going to relieve that constipation. What types of people are primarily going to be given these mu antagonists? Are we going to be giving it to someone who just broke their arm? Who are the people that we're going to be giving it to? Right. The elderly, someone who has chronic back pain, someone who is using it for cancer pain, people who are chronically using opiates and not likely to come off of them anytime soon. And when we talk about them in Thera, we'll learn, that these drugs are, we're going to try our loperamide and our diphenoxylate first. We're going to try our other anti-constipation agents like Senna and Docusate first, but sometimes this is the best yet. So methyl naltrexone, naloxegol, alvomapan, and now dimetadine. Expensive drugs as well. Any questions about this? All right. We are going to wrap up talking about withdrawal, just because I remember a few questions on that when I took the exam. Just because opiates and withdrawal go hand in hand, right? Physical dependence, all that sort of stuff. Remember that when the function of opiate receptors is that they are GI linked. This means that we're going to decrease the activity of adenylate cyclase, which means we're going to decrease CAMP levels. What ends up happening is that the body recognizes this decrease in adenylate cyclase activity, and so it starts to try to adjust for this decrease. So over time, the body will induce adenylate cyclase production. So it says, normally this neuron only has 10 adenylate cyclases. Now we're going to make it have 20. And so what this is going to do is it's going to cause a rise in CAMP levels. Well, we don't want that to happen, right? Because if there's a rise in CAMP levels, then we're going to have pain. So what we end up doing is that we then increase our opiate dose. Oop, I should put this over here. Increase our opiate dose, which is going to decrease the activity of adenylate cyclase, which is going to lead to a decrease in CAMP levels. And then over time, again, we increase adenylate cyclase by the body, and the cycle continues over and over and over and over again. This process of the original dose of the opiate not working because of inducing adenylate cyclase production is tolerance. So tolerance is that is when the current dose of opioid isn't as effective as before. The question becomes why? Because the body increased adenylate cyclase levels to counteract the current dose. So we would say that this person is now tolerant at 10 milligrams. And so that would necessitate an increase in their opioid. The important thing to know, however, is a graph that he showed you, which is actually very, very important for understanding this effect. So this graph starts off where we have adenylate cyclase levels and CAMP levels. And so what we can say is that when someone is not on an opioid, you have consistent adenylate cyclase and consistent CAMP levels. If we begin an opioid, so we start someone on morphine, what happens immediately as soon as we start the morphine is we get a major decrease in CAMP levels, right? After a short amount of time, the body says, oh, something's going on where my adenylate cyclase isn't doing what it's supposed to. So I'm going to start raising and inducing the amount of adenylate cyclase being produced. As our adenylate cyclase is being induced, we're going to see a rise in CAMP, right? We're not changing the dose of morphine at all. So that means that over time, the morphine is going to become less and less effective. Now, in the diagram, he shows, well, what happens if at this moment, I'm going to use a different color. At this moment, maybe the person accidentally took too much and they overdosed and we gave naloxone. Well, what this would mean is that we'd see an immediate jump in CAMP levels. The other thing to consider is, and really the better example is, what if someone just quit cold turkey? Then again, we don't have the morphine available to block this increased amount of adenylate cyclase. So we're going to have this giant increase in CAMP. This giant increase is what withdrawal is. Over time, we're going to see that the levels of, the body recognizes, oh, okay, I don't need this much adenylate cyclase anymore. So it starts to destroy this excess amount. But it's going to take time for someone to go through that withdrawal. And as long as this CAMP level is above its normal amount, you're going to be in withdrawal, which can be as long as 10, 14 days. So it can be really, 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 really bad. Does this make sense? Does anybody have questions about what ends up happening? Okay. What's your question? It could be either one. So it could be that yeah, it's when the activity of the morphine stops. So it could be that they stop taking their, they're a fentanyl user and they're like, I don't want to do this anymore, so they quit cold turkey. Or it could be that someone gave them Narcan, right? Either one is going to immediately block the effect of the opiate and causes withdrawal. So with naloxone, we have to be really careful that we don't just suddenly induce withdrawal in people, right? Because that would be awful to do that to them. It would be a terrible situation. Obviously, we want to use it if they're overdosing because the alternative is death, but we shouldn't just be Narcanning people who are, using but are not overdosing. Does that answer your question? Okay. When we talk about withdrawal symptoms as well, which again is just increased camp levels, we see things like tachycardia. Uh, the the way I want you to think of this as extreme fight or flight, right? Because where do we find increased camp levels? GS linked GPCRs. What kind of receptors are GS linked? The fight or flight autonomic receptors, things like beta, right? So when you think about it this way, it makes sense why we would get things like tachycardia, sweating, restlessness, muscle pain. It feels like you have the flu. It's really, really, really bad. Nausea and vomiting, all these different. It's awful, 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 awful. My question for you is, let's say that someone is a heroin user or a fentanyl user, and they walk into the hospital and they are administered buprenorphine. What's going to happen to them? So someone who is a fentanyl user is administered buprenorphine. What's going to happen? Good points. What ends up happening is the higher the buprenorphine dose, more withdrawal. Why? Why would giving someone buprenorphine, they're on a full agonist, fentanyl, why would giving them buprenorphine cause withdrawal? And then why is it that as you give more and more buprenorphine, you're going to make the withdrawal worse? Think about the pharmacology of buprenorphine. There you go. It's a partial agonist. Remember way back in exam one, semester one, we talked about how in the presence of a full agonist, partial agonists can act like antagonists. Remember that? So when we look at buprenorphine, what ends up happening is that we have fentanyl, which has 100% activity, but we end up giving buprenorphine, which only has 50% activity, but it has a much higher affinity. So what this means is that you give buprenorphine, it's almost like you're giving naloxone, right? Because in the presence of a full agonist, partial agonist can act like an antagonist. So if you give buprenorphine to someone who's on a full agonist, it's almost the same thing as giving naloxone. Will it be as bad as naloxone? No. But will you cause withdrawal? 100%. So you cannot give buprenorphine to someone who is on a current opiate. Otherwise, you're going to induce withdrawal within seconds. And then buprenorphine lasts for 72 hours, I think. So you've just caused 3 days of withdrawal for them. It's bad mistake. Does that make sense? Any questions about that? All right. Now, when we talk about substance use disorder, in treating substance use disorder, if someone is using opiates, one of the potential treatments we can do is giving them buprenorphine. And really what this comes down to is the idea that we're relying on buprenorphine's affinity level. So let's talk about managing their substance use disorder. The first option is detoxification. So someone's going through detox. What is going on here is that you cross taper. No, not cross taper. You cross over their drug onto an equivalent dose of methadone or buprenorphine. Remember that methadone is a full mu agonist, whereas buprenorphine is only partial agonist. So you cross them over from their drug of choice, so maybe they're a heroin or fentanyl user, and you put them onto an equivalent dose of methadone or an equivalent dose of buprenorphine. Once you do that, you slowly decrease the methadone or buprenorphine dose. The idea here is that you're going through this step, right? We're taking someone from this high level of camp, high level of adenylate cyclase, and we're slowly bringing them down. And by slowly bringing them down, we're avoiding triggering withdrawal. The important thing here is that calculating the correct dose is imperative. Right? If you put someone on too low of a dose, you're going to cause withdrawal. So too low, withdrawal. And now you're going to have a very angry patient who's going to say, fuck this, I'm just going to go back onto the street and use whatever it was because it didn't make me feel like terrible. It didn't make me feel like shit. If it's too high, you're going to increase their tolerance. Right? So you're just raising the amount of camp, you're raising the amount of adenylate cyclase. You're not actually solving the issue. The goal here is that you down taper until your dose is 0. Right? So you start on methadone 220 milligrams, and then over the course of, 3, 4, 5 months, you eventually get to 0. Right? Most people end up reusing, going through detox. It's not incredibly effective, just detox by itself, which is where we talk about maintenance therapy. Detox is all about avoiding withdrawal. This deals with the physical dependence of opiates, right? Physical dependence is that someone continues to use a substance because if they stop, they end up getting sick. Maintenance therapy is allowing, creating, what's the best way of saying this? Attacking the psychological dependence. And so this is a lot more of, why are you using? Is it because you are trying to avoid a trauma? Is it because, your entire social circle is pushing you to use heroin or fentanyl? Do you have a family member that is, using you in order to get drugs. There's lots and lots of different reasons why. But the idea here is that you're the patient is off street drugs, but we're not decreasing their dose. So maybe for, while they're working on the psychological issues of opiate use, they're staying at 150 milligrams of methadone. And maybe they're going to stay there for a month. And then once they start to feel ready, like, okay, we'll start to bring it down. It's safer. There, I'd much rather see a patient stay on a high dose of methadone than use fentanyl, right? You're not going to be injecting, you're not going to have a risk of AIDS or HIV, hepatitis, no criminal run-ins. It's just overall a better process. One of the things that we should talk about though is Suboxone, because it's a unique formulation. What Suboxone is it's a film that dissolves under the tongue. Or maybe it's like a sublingual tablet, something like that, depending on what you have. And why would we want to use both buprenorphine and naloxone if both are going to, be in the same tablet? Well, what's the risk of someone having buprenorphine and naloxone at the same time? Yeah. So if fentanyl is 100% activity, buprenorphine is only 50% activity. Naloxone is 0%, right? So what is going to happen if you have naloxone, but you try to use buprenorphine, is you're not going to get any of the effect of the buprenorphine. So why put it in the tablet, right? If we put it in this film, wouldn't it block our buprenorphine and then we're going to cause withdrawal? What's we're using is we're relying on the absorption. So buprenorphine absorbs well. Let's try spelling correctly. Absorbs well. Naloxone is absorbed very poorly. So in this film, we're able to administer the buprenorphine, it's able to get into the body, but none of the naloxone is getting into the body as well. Great. So that means that we are, able to have the buprenorphine do its thing. Why include the naloxone? What would be the purpose then if none of it gets absorbed? Stops the misuse. How though? How does it specifically stop the misuse? good thought. Essentially, what happens if the patient tries to inject it or snort it, snort a ton of them at a time, inject a ton of it at a time, you're going to be then you're like Sierra said, you're essentially Narcanning yourself. And then this prevents misuse. So this is what allows Suboxone to be dispensed at community pharmacies, right? And that we don't have to necessarily worry about someone misusing their Suboxone, because if they try to take it any other way than oral, you're going to be getting naloxone, and now you've just fucked up your high, and you're probably going to cause withdrawal, and it's your own fault. Any questions about that? There will definitely be a question about Suboxone and what the purpose of naloxone is, because it talks all about affinity, and it talks all about absorption. So definitely make sure that is something that you understand. All right. We are going to wrap up here. Tomorrow we'll start on migraine and the sedatives. And then just take a look out on the Google Classroom for updates on the weekend. Great question. So what ends up happening with the detox and like the fentanyl question is that if someone's going to be detoxing with buprenorphine, we're going to wait for the fentanyl to leave their system for them to start going through withdrawal, and then we're going to give them buprenorphine. And so what essentially we're doing is we're taking away the opiate completely, and then we're replacing part of it. Usually detox with buprenorphine is for someone who's on smaller doses of opiates. So maybe they were like a prescription drug user, like they abused oxycodone or hydrocodone. For someone who was fentanyl or heroin, you're probably going to be starting on methadone, and then eventually over the like a few months, you're going to be able to get to Suboxone. That's a really, really good question. So we have to wait for them to get rid of all of their drug of choice first, and then we'll give them the buprenorphine. It's a good thing I'm in this line of work, because detox is not a very well known subject at all. That sort of stuff. All right, cool. Well, I will see you all tomorrow. Let me know if you have questions.
Thank you, Gabe.